The question of this presentation is, what is the added value for health care with medical teleconsultation given to general practitioners? The focus of the answer is on patient vulnerability to medical error. This experience is embedded in a unified and universal health system of a Western European country. The healthcare is based on the referral and counter-referral from one level of care to another through transition care, according to the complexity of the occurring disease. The general practitioner is the point of entry through which the patient accesses the health system. He is the one who does the triage. He addresses the low-complexity health problems himself and refers the medium complexity ones. The 5 most common medical errors resulting from the healthcare process in the health providers' relationships, transition care, are 1. Clinical tests, laboratory imaging or other, are unnecessarily duplicated or mishandled or ignored. 2. From the beginning of the healthcare process, the differential diagnosis diagram is inaccurate, and therefore the subsequent steps of the diagnostic track misleading. 3. In transition care, health information comes through either incomplete or wrong. 4. The health providers involved, above all specialists, make decisions with poor coordination between them. 5. The general practitioner does not reconcile the specialist's prescriptions or does not monitor hazardous therapies properly. In this study, we identified patient vulnerability to such medical errors and the impacts of medical teleconsultation on them. The entire teleconsultation system works through the web. The general practitioner can apply for support regarding a case of medium-high complexity in an internal medicine patient whose problem is still unsolved through the normal healthcare process. In the application, he profiles the case through a text and attaches health information in other electronic formats. He also makes clear the focus of his application and expectations. The application is shared within the 7 internal members of the teleconsultation system, who make decision on whether the case may benefit from the procedure by the end of the day. If not, the case is politely rejected. The general practitioner is requested to complete the health information in electronic format as best as he can. A teleconference is scheduled and held within 3 days' time. All the internal members of the telemedicine system, the general practitioner, and external case-relevant consultants participate. The general practitioner opens the session of the teleconference by presenting the case. Thereafter, a differential diagnosis diagram is drawn up and discussed. The participant plans the action to take to other external consultants at even the hospital level if needed. In the following days, through the general practitioner, the patient gets information and undergoes the recommended clinical tests. When they are reported, a final teleconference is held either without or with the presence of the patient for conclusions to be drawn. 1 year later, follow-up and evaluation of the case is carried out with the general practitioner. Satisfaction, success, or shortcomings are discussed. Within this frame, the teleconsultation system supports the patient's healthcare process by both counseling the general practitioner and directing the patient to higher levels of care. This study was carried out on 80 cases. In 17 out of 80 patients, 21%, the results were below the expectations. Communication problems never occurred. The poor adherence to the recommendation by either the general practitioner or the patient caused almost all shortcomings. Throughout patient processing, medical error vulnerabilities were observed in 39 out of 80 patients, 49%. Many of these patients encountered more than one medical error vulnerability, namely Clinical test mishandling and duplication occurred in only 6 patients, 7%. Inaccurate differential diagnosis in 17, 21%. Inadequate information flow in 15, 19%. Poor coordination between health providers in 12, 15%. And poor monitoring of hazardous therapies in 10, 12%. Of these 39 vulnerable patients, in 22, 56%, the medical teleconsultation managed to cancel out or even prevent such vulnerabilities. In 6 more patients, 16%, medical teleconsultation contributed to mitigating them. In the remaining 11, 28%, medical teleconsultation had no significant impact. The inadequacy of health information transfer was the only type of vulnerability that was challenged successfully in over 80% of cases. The conclusions are that 1. Medical teleconsultation implemented on a large scale may improve the quality of patients' health care processing by reducing or mitigating the probability of medical error and therefore also increasing patient satisfaction. 2. More action are needed to eliminate patient vulnerability to medical error, such as the full implementation of the citizen's electronic health record, which is supposed to secure the proper health information flow in transition care.